towards the end. We're going to have some Q&A for about 20 minutes towards the end. So as the preparations are, as the presentations are being made, please, you can be posting some questions in the chat box, and I will be looking at them, and we'll choose some we'll pick on some, and we'll have our panelists address some of the, your questions that you may have. So mental health and mental illness is a topic that we've been having more and more discussions. And what we know is that the burden of mental disorders across the world is actually increasing. The unfortunate bit has been that mental health financing has lagged behind, because you all know that there has been an underinvestment in mental health in many countries, including our own, for many years. However, we know that there's an imperative to invest in mental health because, one, investing in mental health is a human right, and this human right is protected under Article 43 of our Constitution. Also, it brings about an economic benefit to the nation when someone with a mental disorder is treated and then they are productive again. That brings about an economic value. Then there's the social value of investing in mental health, which means that a person who then gets treated would have their independence of thought as an individual restored, and they can go on to participate in a productive life, form friendships, form families, and other social interactions. The SDGs, when you look at the SDGs and you look at, reflected in our own country through also our own, local blueprints such as the Vision 2030 and the Big Four agenda. If you look at the achievement of these aspirations, this cannot be attained without tackling the issue of mental health. And whether you talk about poverty and the rest, you may not be able to, we will not be able to attain any of these SDGs without good mental health in our country. And so that's another reason why we should think about mental health. And one other reason is that mental well-being in itself contributes to the overall physical well-being of an individual, practically demonstrated through the finding that persons with mental disorders actually have reduced lifespan. They have a reduced life expectancy, of up to 10 years. So treating a person with a mental disorder also protects them against the other disorders such as cancer, such as heart disease, diabetes, mellitus, and so on and so forth. And so, ladies and gentlemen, these are the reasons why it's important to invest in mental health. And the big question has been, how can this be done? What models can this be done? And a lot of people have said, okay, it could be through reforming NHIF and so on. So this afternoon, I'd like to hear some of the details in this, so that we know, what must be done really to increase mental health financing, to make it sustainable. And we know that financing is so important when it comes to protecting the individual against what has been called the catastrophic losses, due to out-of-pocket expenditure and so on. And so, so to start us off this afternoon is Miss Charity Muturi, who will be talking to us about her experience on using NHIF and proposals for comprehensive coverage, from her perspective. And Charity, we've been working with her in this mental health space. She's a mental health advocate and a policy champion, using her lived experience and her position as a caregiver, and she has served on the National Mental Health Task Force, which completed its work last year. And she also sits on Global Advisory Committee and UHC, NCD Policy Research Committees. And she's one of the leaders of the Non-Communicable Disease Alliance. So karibu sana, my sister Charity, to take us off. Welcome, Charity.
Okay, thank you, everyone. Sorry, I was unable to unmute from my end. So thank you, Priscilla, for doing that. So I am grateful for the introduction. Yes, I have lived experience with a mental health condition, and I also care for parents with 6 non-communicable diseases, including a mental health condition. Now, I apologize, I have my video off because we are at an MOH meeting on disability assessment, and all the rooms are in use at the moment. So NHIF is a very important institution in this country, both in covering health issues now and also for the upcoming universal health coverage for all. There have been challenges in accessing NHIF services for people with mental health conditions or others who identify as different disabilities. And for this reason, I call upon the directors of NHIF to consider making increments in access to services. So the positives, I was diagnosed in 2015 with bipolar disorder. At that time, I had private insurance facility. And so I had very good due diligence in terms of diagnostics. Before I was given a bipolar diagnosis, I was sent for a thyroid test to rule out thyroid issues, which are in the family, and also an MRI to rule out brain injury. And so I felt that there was a lot of due diligence done. I was very lucky to be able to afford quality medicine, partly with NHIF and partly with the private insurance cover. Soon after, in fact, that cover ended in 4 months, and I've been mainly using NHIF since 2015. And so Mathare has been my facility of care. The nurses are very kind. We look out for each other as patients. I have been able to access, when I am admitted as a patient, as an inpatient, then Mathare, NHIF has fully covered the bed charges or the accommodation charges. My second visit in 2019, I had 6 sessions of ECT, which were also covered by NHIF. I moved from, both in my admissions, I've moved from general to amenity or private ward, and NHIF has covered. And also lately, Mathare has introduced newer medicines, including clopixol, fluanzol, olanzapine, epilim, and others, which NHIF covers on inpatient for myself and for other patients. However, as mental health patients, we are financially disadvantaged, and the majority of us are dependent on family for livelihoods and even for health access. And it leads to a lot of out-of-pocket expenditure, specifically for outpatient, because as much as the drugs are being increased, the outpatient cover is so limited to 100 shillings a month. And that means that even olanzapine, which is the cheapest second generation at 10 bob, at 10 shillings a tablet, which would come to 300 a month, then is not covered. So you find the inpatient cover is good, but the outpatient cover, you know, by not being comprehensive, pushes us to have more inpatient services. So apart from out of apart from out of pocket expenditure, we have, you know, loss of income as a result of our illnesses. And sometimes by the time we are being admitted, we've had loss of property, loss of jobs due to the nature of our illnesses. And so when we get in the hospital, we are covered well by NHIF as inpatient, but the lack of aftercare through outpatient services and through other socioeconomic activities means that we are constantly in a cycle of poverty and hospitalization. As caregivers, because like I mentioned, I do care for a family member who has a mental health condition. And usually I find I am not given enough information to be able to take care of this person. So the caregiver struggle I have found for myself is harder than the struggles I have as a patient. And so not having support as a caregiver or it being prioritized, whether by the Ministry of Health or the NHIF, affects how well I'm able to take care of my patient. And a lot of patients in Kenya, currently our cultural understanding, especially for those in the lower income bracket, you find we'll usually look at mental health symptoms as a spiritual issue or an issue of curses or demons or things like that. And so by the time we have people coming to the hospital, which we see every Tuesday, especially when people are being brought in for care, they come in when they are very severe because early intervention has not been done either by the general doctors or these people did not know it was a psychiatric issue. And so you find, like on a typical Tuesday, you'll find very many big cars, some good Samaritans who have brought people who are unwell, but the majority is family who do not believe in the return on investment for mental health patients like myself. And so when as patients we have issues with coverage, we assume that it is NHIF that are also not investing in us or seeing the need to invest in us. So I have heard that NHIF has spent over 200 million on mental health, but I do not feel the impact of that 200 million. And the people in our support groups do not feel the impact of this 200 million. And the question is this money paid to approved facilities? There are issues that patients are asking. Is this money legitimate? Are there any illicit issues happening behind the scenes? Because as patients, we do not feel the impact of this 200 million. And in terms of out-of-pocket expenditure, I think for me, meds is the biggest one, medication, because when I am admitted at Mathare, my family comes with medication. Like they come to see me, they'll bring juice and whatever, but they have to come with medication. Otherwise, I don't get medication from the hospital. So we have an issue with the consistency of medication. Yes, it is true that we have better quality medication, not as much as we need, but at least it is a start. But it is still, you still find a lot of times the institution does not have medication. When we visited as a task force, the hospital did not have a single injection. And so we had a pregnant woman climbing the fence and nothing could be done for this patient. And so while we are happy about the drugs being increased, there is no consistency of supply of quality medication. And I'm giving Mathare as an example, but these things cut across a lot of public institutions where we have level 5 facilities that provide psychiatric care. So the other issue of concern is that after NHIF registration, the cover matures in 2 months, which we feel is unnecessary, that it can be reduced to 1 month. Last year, we engaged in NHIF on the issue of many of our patients not being able to raise the 500 due to the challenges as a result of COVID, and they introduced an amnesty for 1,500. But even after the amnesty, we still have to wait for 2 months to wait for the maturity. And so we are calling for reducing that to a month as well. Right now we have biomedical registration, which requires a code on arrival to hospital. But then you find that then the code goes to the card holder's number, and probably that is the husband, and the wife has come for treatment and they don't have it. So we're having a lot of inconveniences, having many calls to get someone to send you the code. It expires in 3 seconds, and so it is an inconvenience for many families. Now, the current package at Mathare has 300 shillings per quarter on outpatient, which translates to 100 shillings a month, which I said, does not only covers the first generation drugs that have adverse side effects. So like I said, even the cheapest olanzapine cannot be covered on that. So it's very unfair for NHIF to be saying they are covering, but in real sense, majority of patients are not able to get adequate support on outpatient. The inpatient cover is 3,500. Sorry for the noise in the background. 3,500. Though most patients actually think it's 1,000, including myself. So it's only recently that I got to know that it is 3,500, but at least it pays for everything we are able to access on admission. It also pays for medication when it is there. But in the time of inconsistency, then we are not able to get that. The rehab facility, which unfortunately has been closed during COVID as it was used as a COVID ward, has been charging 60,000 shillings for 3 months for non-civil servants. Civil servant is covered in full, so you find majority of patients at the rehab are civil servants. But those that pay 30,000 still complain that sometimes it goes, the cost goes above, whether it is because of the detox or the consultation or drugs. And so this 60,000 is not adequate. Then also, NHIF does not provide transparency through a service charter. So you find as patients, as caregivers, we do not know, we are not made aware of the amount that should be due for us, so that we should be able to get, or the time that each service should take. And so then we are not empowered enough to fight for our rights. And so a service charter would really help for us to be able to see what is due to us and at what time, so that we are able to complain. Now, patients feel that if the outpatient cover does not cover comprehensively, we'd rather not have it at all than have it at such a low level. And the other thing is, families also say they struggle to choose one outpatient facility because different family members need different specializations. Sometimes you have one person with comorbidities, and so having to choose one outpatient facility for the card holder, and you're taking care of different specialties, causes a problem for many of us. And then we have a lot of adult children who are still fully dependent on their parents for cover. And like I said already, patients and caregivers are disadvantaged financially. So you find like there's a caregiver who has 4 adult children, and so it becomes, she doesn't find the cover being helpful to her, because the 4 sons cannot get cover, whether it's inpatient, because there's a cap of 180 days. If these 4 sons are admitted through the year, even for a month each, then it's not covered. So I think NHIF has not thought through the issue of mental health conditions being hereditary. We have had recently a mother and 2 daughters admitted at the same time, and this cap of 180 days brought a problem. So it should be looked into. In terms of the institution, and this is Mathare Hospital specifically, NHIF have not paid claims as far back as 2016. And there are some years that have even been written off before that. And that means that it affects the services that we receive as patients. Now, after already putting a cap on what each patient should get, and every paying patient has a right to services, the NHIF still provides an institutional cap per quarter. And most times you find that the monthly claims exceed the institutional cap for the quarter. So at the end of the day, we experience a lot of injustice as patients because we are not getting enough cover at individual level, and then there is another cap as an institution. For me, I don't understand why it is there. Then, as a task force, we recommended working towards mental health care and services in public health facilities, like we have had for Linda Mama, which can be either through a special card for persons with mental health conditions or through the disability card. However, hospitals are complaining that Linda Mama claims are not being paid, so they'd rather even just give free services. And so we feel that NHIF needs to address this, that if there's a Linda Mama cover, it is paid so that when we as persons with mental health conditions push for free cover, we are able to get that. Now, poor outpatient coverage encourages more admissions. And so we are calling for better outpatient coverage. Private clients of NHIF claim inconsistencies in amount covered by hospitals. So doctors' consultation, counseling, therapy, occupational therapy, physical therapy where necessary, especially where it is in issues of injuries. NHIF should look into that so that even for private patients, they are able to be covered fully. Psychiatry is moving away from long stay facilities to community mental health services with an effort, with a focus on primary health care. So NHIF does need to focus more on prevention, early intervention in primary health care, and stop looking at mental health as a long stay psychiatry issue, but something that should be included for every patient, that there should be minimum standards of screening for mental health. Like I mentioned, my parents have 6 non-communicable diseases. I see how these diseases affect their mental health. And there is substantial evidence to suggest that mental health services, when integrated in physical health programs, will contribute to better overall health outcomes. And that will be a very big win towards UHC being a success. Integrating high quality, rights-based, evidence-based mental health practices in health systems, again with a focus on primary healthcare and community-based services, will go a long way. The Global United Mental Health Investment case is that this is an economic argument. There is $5 of productivity for every 1 shilling invested in common mental health conditions. So, and then we also have the rights-based model that is aligning to the Constitution, mental health laws, UNCRPD, and globally as well. There was a 2019 political declaration of the high-level meeting on universal health coverage that stated that UHC cannot fully promote the right to health without the inclusion of mental health. Global targets for countries is actually 80% of countries to double the number of community-based mental health facilities and integrate mental health into primary health care by 2030. Global health options can also be pursued, especially for private sector, which IFC promotes. We have a KPMG article, the Exploring the Physical Space of the Health Sector in Kenya, health budget reprioritization has proven to increase the gross domestic product in DRC. We also have Nigeria and Rwanda who have impressively increased their universal health coverage up to 90% through community-based care model structured to charge citizens based on their economic status. So what is my call to action? What I feel would work for us, and this is something I have asked several patients across different mental health conditions, including substance use disorders, is to move the outpatient package from 100 shillings a month to 1,500 shillings a month to be all inclusive of consultation, proper diagnostics, counseling, and so on. And for the inpatient to move from 3,500 to 5,000 per day, so that it can cover the better medication that is being increased. And then for the rehab, from 60,000 to 100,000 per 3 months so that it is able to adequately cover without going into out-of-pocket expenditure. And also, the inclusion of lived experience is a right according to in policy and legislation, according to the WHO Quality Rights Program, which MOH is championing. And so we are calling for our inclusion within the NHIF board, within the UHC committee that we've been trying to get audience with, and they are not giving us any audience. And I do understand we cannot have it for every health issue, but at least if we have one person representing communicable and another representing non-communicable. NHIF, please ensure better delivery of quality drugs, because even when we come to you and you send us back to KEMSA, patients say NHIF is letting them down with drugs. So it goes down with your reputation. And so it is important to agree with KEMSA that when they do not have a drug, there are agreed pre-negotiated pharmacies that we can go to, because currently KEMSA have to give permission for what are they called? These public health facilities to be able to buy. And sometimes they give approval after 2 months. So how many of us patients have struggled over those 2 months? Focus on outpatient coverage as we integrate mental health into health systems. Either renegotiate or remove this institutional cap that puts an additional burden on the hospitals. And then health workers endorse wholesome approaches to wellness rather than disease management, so that we can have prevention, self-care, intervention, treatment, aftercare, with reasonable accommodations for socioeconomic support for patients and caregivers, and bring in stakeholders to provide social protection, disability protection, gender. I believe that these changes can help us align in providing access to the highest attainable standards of health without suffering financial hardship, in line with our constitution and universal health coverage. Thank you.
Thank you so much for the presentation. Sorry for the echo. So we are going to move on to our second presentation, which will be done by Dr. Isabella Maina from MOH. Thank you.
Right. Thank you very much. I think Priscilla, sorry, I think I got disconnected towards the end of Charity's presentation, but I'm happy to be back. So thank you very much, Charity, for that presentation. And in case we have visitors who have just joined us, or participants who have just joined us, this is a webinar on mental health care financing, organized by the Ministry of Health. And we are having 3 panelists this afternoon. We have Charity Muturi, who has just given her presentation. And then later we'll also be hearing from Dr. Samson Kuhora from NHIF. But next we are going to listen to, we're going to be listening to Dr. Isabella Maina from the Ministry of Health. So Dr. Isabella Maina is the head of health financing at the Ministry of Health. And she's a public health specialist, currently working in the Ministry of Health as the head of the financing division, charged with the development of health financing policies, strategies, and guidelines. And she's previously worked in the UHC coordination department, charged with defining the UHC agenda, including the roadmap and guidelines. And she has extensive experience in health systems, planning, M&E, both in Kenya and beyond. And so we are very glad to have her this afternoon. And I am certain that as she tackles the topic of UHC, mental health parity and equity, she's going to be responding to even some of the questions that already became evident from the presentation by Charity. So karibu sana, Dr. Isabella, for your presentation, and you have 15 minutes. Karibu.
Okay, thank you, Chair. I think I'm not able to unmute. Hello?
We can hear you now.
You
Dr.
can hear me now,
Isabella?
yes. The host had denied me services for unmuting, and I'm not able to turn off my camera. I'll try as we continue. I don't know whether it's from the host side or all that, but thank you, Chair, for the intro that you had. So I will not repeat the issues of rights to health as enshrined in our constitution, what the UHC policy says, what the health policy says, all focusing on ensuring Kenyans achieve or attain the highest standard of health. I would like to thank Charity for her presentation. Indeed, it has covered most of the areas, and I'm even wondering whether we just go straight to plenary. However, allow me to just touch on a few slides. The topic is on mental health parity and equity, but I wanted us to broaden that topic and look at it in terms of, in the context of UHC, as has been described by our previous speaker. So this is the outline of the presentation. We'll have an introduction, a definition, look at the UHC and trends in financing in Kenya. And this is broad financing because the overall financing also has implication on mental health financing. Then look at the issues in mental health financing that have been well articulated by our previous speaker, and look at proposals. Now, this is Kenya demographics in terms of population, a broad-based pyramid of the Kenya population, meaning we really have a young population. Actually, from 2019 census, our population, the average age is about 19. But then as health workers and as teams who work in the health sector, we also have to consider this bulge here, 80 plus, and basically take care of everyone while focusing on this broad-based pyramid. Consider that we are having more and more people who are aging, more and more people living longer, you know, an increased life expectancy, and therefore, as we plan for our health services, whether it is mental health or otherwise, we have to consider this population pyramid and the demographics. Now, when we talk about mental health parity and equity, here we are asking for equal treatment for mental health as other services that are considered essential. Broadly, when WHO talks of essential services, basically you look at the burden of disease, the population that is affected, and I am sure we all know the estimates that are done by various bodies, including WHO, including the Institute of Health Metrics, in terms of years of life lost, disability adjusted life years, based on the various burden of disease. And therefore, many countries have considered burden of disease on what we call, let me say, the usual conditions. And some of them have been left behind, especially mental health. And I really just want to emphasize what the previous speaker has said. Although the mental health may not appear high in the burden of disease, the ramifications or the implications are very dire in terms of the social impact, the economic impact, and all the others that are articulated. And therefore, when you talk about parity, we want to look at health insurance providers, in this case, NHIF, the private sector, that they are able to cover mental health in the same way or in the same amount that they cover other conditions, be it surgical or medical. But Chair, why I have put the health insurance providers in bold and star is that we need to be broad here. Let's not just look at NHIF, because health financing is very broad. It's not just the insurance. We have to look at county government as a source of health financing for mental health and other health services. We have to look at national government. We have to look at the private sector, and then the public health insurer, in this case, the NHIF, so that this discussion is broadened rather than just the NHIF. And therefore, here we want to look at the scope of benefits. For example, when you talk of the county government budget, how far or what benefits does that budget provide in terms of mental health? When you talk about NHIF, what is the scope of benefits? And I think Charity has articulated that very well, including the inpatient cover, the medication, and all that. What are the payment rates? Is the mental health services or the benefit package disadvantaged? Are we having maybe surgical services paid better than the mental health services? And then who are the contracted providers? And I had drawn this act that was done in the US in 1996, just requiring that all insurance companies cover mental health without any discrimination and cover the services just like they cover other quote unquote essential health services, because we know mental health is also essential. When you talk about health equity, we are saying that we want that all people can experience the optimal health. In this case, if we talk about mental health equity, we want to ensure that all Kenyans can experience that, access to mental health, quality mental health services should they need them, just in line with UHC. And we have to get rid of all the barriers, as mentioned, be it lack of human resource, be it the issue of financing, be it the issue of distribution of health infrastructure across board. Now, we want to look at mental health in line with UHC. This is called the UHC cube, Chair. If you look at what is horizontal line there, giving the population coverage, the question we want to ask ourselves is, what proportion of Kenyans are covered through mental health, with mental health services? Sorry, Chair, there's a bit of noise. If people can mute. So the first question we ask ourselves is that, who are these people? What is the proportion covered with mental health services? So that we are talking about all Kenyans. And the idea is, even as we reform, we want to ensure that all Kenyans are covered. Right now, you will tell us, maybe those who are mental health practitioners, how many Kenyans are covered with the services. The other one that is almost diagonal, where we have services which are covered, which services are covered? For example, when you talk about the private sector or NHIF, or even the input-based financing from the Ministry of Health or even from the county, what services are we covering? So the idea is that as we reform in line with UHC, you want to fill that box so that we have more and more mental health services being covered. And Chair, the word here is progressive coverage with mental health services. We know we cannot achieve that in one day. The idea is to move and progressively cover services. As well articulated by Charity is that we want to protect Kenyans from direct out of pocket, and therefore the other tenet of UHC is to ensure that Kenyans are not going into poverty as they are accessing health services, in this case, for purposes of this webinar, as they're accessing mental health services. So we want to ensure that they have, some sort of protection, either through an insurance, either through a fund, as has been articulated earlier on. And we shall see what the proposals are. So this is basically a UHC cube, but you may want to just discuss it in terms of mental health. So the idea is that whatever is blue, if you think of it as mental health, you want to ensure that horizontally you are covering more Kenyans with mental health, that you are increasing the scope of mental health services. And then as Kenyans access or seek mental health services in our health facilities, that they do not suffer from financial hardship because of the out-of-pocket payment. And we shall see how that should be done. So without belaboring this, because it's the same as the cube, we want to look at equity in resource distribution. Again, here, it's not just financial resources. It is also issues of, let's say, human resource. For example, the psychiatrist, if it's a psychiatrist, nurses, the medical practitioners, be it general practitioners, equipment, how well are they distributed across board? How efficient are we using the services, the resources that we have in the country? How responsive are we to mental health needs? And I think our client here, Charity, has really elaborated whether we are responsive or not. Do we have utilization relative to need? The quality of mental health services, and I've elaborated the issue of financial protection. Now, Chair, looking at the budget, so that we also do not just look at NHIF, these charts show where health budgets come from. Now, the yellow that is on top, for the ladies who are in this webinar, appreciate the yellow. For the men, that is the color that is on top, 23%. It means in 2015, 2016, 23% of our health budget was from donors. And you and I know that mainly donors cover some of what is called priority programs, for example, the HIV/AIDS, malaria, TB, and others. So 23%, you can already imagine where that goes. And then 6%, what is gray, that is the second one, is from private. And then 31%, this is where the problem is from out of pocket. Okay, 31% is from out of pocket. Sorry, Chair. So 31% is from out of pocket, and then 40% is from the government of Kenya. Now, out of this 31%, because it's where the issue is, you would want to ensure that Kenyans are paying less and less from out of pocket. A study done on mental health, or the data that we have from studies conducted in Kenya on mental health, show that families with somebody who suffers from mental health illnesses usually spend about 51 USD. That's about 5,100. And you can imagine with our poverty levels in 2019 census, about 43% of Kenyans are living below the poverty line. So this 5,100 per household is quite high. So the idea is that as we move towards UHC, you want to increase government financing so that the blue becomes more, less and less from the out of pocket. And of course, we know that most of the donors are transitioning from most countries. So you want the government to take up this funding so that we can protect from all Kenyans, whether it is from mental health, whether it is from any other illnesses, so that we are broad. Okay. Chair, again, if you look at this budget, this is just a sample from the budget from counties since devolution. I am focusing on the year 2013-14 when we devolved. The national government, that is the lower bar, which is about its pitch in color. In 2013-14, the national government was receiving about 36 billion. At the time of devolution, the counties received 42 billion for health. increasing that up to 2017-16, you can see the budget has increased. If we had the figures for 19-20, the budget has increased. However, despite the increase in the absolute figures in terms of budget, if you look at the line graph that is on top, it's almost the same, you know, from 7.8, 5.5. Right now in 2017-18, it was about 8.2%. And if we look at recommendations by WHO and other bodies, for a country to cover health services very well, we need to allocate about 15% of the government budget to health. Now, if you look at 2017-18, the country only gave 8.2% of the government budget to health. That tells you that there's a gap overall in all health services. If you look at the heading there, out of that 8.2, or out of the government budgets to health, only 0.01% goes to mental health. So that's really meager given the burden of mental health in the country. But you can see the overall picture is that we are still not yet there. We are allocating 8.2%, while what we call the Abuja Declaration, a commitment by all governments, is that we should be allocating about 15% so that we can be adequately covered for health services. Chair, again, as we talk about parity, as we talk about access to mental health, it is important to note that only 19% of Kenyans, that is what is at the bottom there, 19.1% of Kenyans have a form of health insurance. So what does that mean? That even as we talk about parity, even as we talk about improving NHIF, even as we talk about NHIF ensuring that we have the necessary commodities and medication, it means that this will only be accessible to only the 19.1% of Kenyans who have an insurance. And mind you, this 19.1 includes you and I, who are in the formal sector. It tells you the 43% of Kenyans who are poor do not have a form of health insurance. So broadly speaking, if these Kenyans, the 43% who need, if the 43% who are poor needed to access mental health services, they are not able to access because they do not have a form of health insurance. Therefore, we need to cover these Kenyans so that they can access any service, including mental health. And then out of the 19%, NHIF covers the 17%. The other 2% are covered by the private health insurance. Chair, why I'm raising this is that so that the recommendations are broad, that we are looking at the whole country, that even if we were to say we expand the benefit package for NHIF, which I think we need to, it will only then target a very small percentage of Kenyans who have a health insurance. So the battle is broader than just, you know, than just the benefit package. Now, if we look at the distribution of the 19% that we have seen, and I'm asking the participants just to concentrate on the line that is black, the rest that is blue and purple and all the bar charts are just disaggregating the 19% into who is covering. The blue means that out of the 19%, majority are covered by NHIF. What is lime green there means that out of the 19%, few are covered by private insurance. And what is purple on top means that out of the 19% insurance, the rest are covered by community-based health insurance. But what is critical for us, Chair, is the line chart. Out of the poorest in the country, only 2.9% have a form of health insurance. Okay, meaning for purposes of this webinar, if the poor persons in Kenya who are over 43% were to access mental health services only through an insurance model, only 2.9% would access. That tells you that we are leaving so many Kenyans, and no wonder the high out-of-pocket expenditure. If we go to the second quintile, the wealth quintile, only 6.4%, have a form of health insurance. And as you increase in terms of wealth, if you go to the richest quintile, I'm assuming that the people in this panel belong to this quintile, except maybe me, that only 41.5% of us have a form of health insurance. So Chair, you can imagine if the richest it's less than 50% who have a form of health insurance, it means that we have a long way to go as Kenyans to ensure that Kenyans can access all the services they need without the suffering financial hardship, be it mental health services or otherwise. Now, I got this from the mental health policy and also from other documents, which I agree, I believe that the people are well versed with, that the burden of mental health in the country is quite high. And we have heard from Charity that if you do not take care of mental health at outpatient, you are likely to have more of the inpatients. The data is showing this, that 25% of those in outpatient have a form of, mental health, the common mental health issues, be it depression and others, and then 40% of inpatient. That tells you the burden is quite high. Mental health services are widely underfunded, and we have seen that in Kenya, out of the government budget, only 0.01% budget comes from government. If we were to disaggregate the 30% that counties allocate to health, probably this would even be lower. And I think this is something that we need to look into. Currently, there's no separate budget for mental health in the country. And Kenya is ranked among the 28 countries with no budget for mental health services as a separate budget. The scope of benefit package is limited, and I think we have NHIF. Dr. Kuhora will be taking us through the benefit package. I really do not want to belabor on that. We have seen the beneficiaries are also limited. We have said with only 19.1% of Kenyans having a form of health insurance, even if you are to expand the scope of benefit package, it will be very good for the 19%, but then we need to bring the other 89.9% of Kenyans who do not have a form of insurance. Majority of them being in the informal sector, because we know the formal sector are covered through statutory deductions. And then the extent of integration of mental health services is limited because of the barriers that we know, be it distribution of infrastructure, be it distribution of the human resource, the issues of stigma, HR capacity, and all those other issues that limit the integration, that limit the equity in mental health, including the financing that we are discussing. Now, why I want to focus back on the second last point, that the fact that beneficiaries are limited is not just because of insurance. We also want to look at the input-based financing. Remember, we said that we want to look at financing broadly, that when NHIF is taking care of the 17% who are covered through the NHIF, the private sector is taking care of the 2% who are covered through the private sector. We also want that the other beneficiaries who are taken care of through the line budget, either at the county government, mainly at the county government, because they're in charge of service delivery, that this is happening, that county government is also investing in preventive promotive health services, screening, as had been said, and we shall see what is proposed on that in that case. So going forward, again, broader suggestions so that we are looking at broader view. We are looking at a vision that will help us also take care of mental health services across board. So going forward, Chair, the proposal is that we want to ensure that we have one single national scheme, UHC scheme, one single UHC scheme that brings all Kenyans on board. We have seen the 19%, we have to take care of the 89 81.9%. Why Charity said that even when they go to the outpatient, the cover only gives them maybe 100 shillings, or it may be because the pool is very limited. With the principles of insurance, when you have a very limited pool, the contributors are very few. Remember, you are spreading that pool to so many other people. So it means that it's like having a small cake and you're sharing it among many other people. How can we enlarge the pool, bring everyone on board? And we know that when we bring everyone on board into the insurance scheme, then we'll have a bigger cake, and then the people who will need that will be fewer, because when you bring all Kenyans, it's not that all of them will need medical services or services for mental health in this case at one go. It means that you will have enough resources at your disposal to be able to take care of everyone, meaning that even the payment rates, the scope of the benefit package will be better. So this is one of the broader reforms that you want to bring Kenyans on board through a single national scheme with a comprehensive benefit package, so that those who are poor are taken care of by the rich. And then you can cross-subsidize among the sick and the healthy, because I will contribute as minor, assuming I will remain healthy, but my contribution will be used by that person who will need that services. So you can imagine 81.9% of Kenyans being outside. It means that we are only, and the contributors, mind you, the contributors who are voluntary are those who have chronic ailments. So they are contributing very little, and they are also spending that amount. You can bring the 81.9% into the pool. It means we'll have more at our disposal. And the other proposal is that we increase the scope of coverage. We already saw the dimensions for UHC. We need to increase the population covered with mental health services. And what that entails, Chair, is that apart from the financial aspect, we also have to look at these other resources, human resource. What are the skills? How do we train more and ensure that they are all in all counties, at all the corners, yeah, of the county, so that again, we do not just talk of Mathari Hospital. We want to ensure that when we go to Garissa, the population of Garissa are also covered with services. The other idea is to mandate health insurance, and this is in line with giving that bigger pool. As I said, bring all Kenyans to the pool, let all Kenyans, those who can pay for health insurance. And I'm sure all of us heard about a month ago, the CS Treasury saying that Kenyans will be paying 500. This is in line with this, because the more we bring people on board, the more we'll be able to cover all services. And then the government of Kenya should be able to cover, and the proposal is that the government will cover the poor, those who can't pay. So you mandate health insurance. Those of us who can pay for insurance, and those who cannot pay are paid for by government. The other mechanisms of increasing financing or increasing resources for mental health and other services is to have innovative financing mechanism. For example, taxing for sugar, taxing for soda, taxing for cigarettes, and directing that to health. And then well articulated also in the mental health policy is the public-private partnership in terms of financing. And then expanding the scope of the benefit package for UHC, I want to assure the participants here that this is something that is happening. The goodness with the UHC agenda, the team, including with NHIF, and the ministry has looked at how we can expand the scope of the benefit package. And right now, and I'm sure Kuhora will tell us this, is to see how we can expand the scope of mental health services, and not just the scope of the health services, but also the payment mechanisms, including the rates that are paid to the providers. And then something that was well articulated by Charity is to focus on preventive promotive health services. Remember, I keep cautioning that the delivery of health services or delivery of mental health services, and to ensure parity, is not just the NHIF. So we also want to look at the other side, the input financing. How will we ensure that the county governments and the national government invest in preventive and promotive health services, and then reforming the provider payment mechanisms and the rates to the providers. Therefore, again, coming close to mental health, we need to improve the funding from both national and county government. Collaboration among all the players. Again, we cannot do it alone. The government cannot do it alone. It's bringing the private sector on board. Integration of mental health program into other health programs. And I really do not to elaborate this. I think Charity said it very well. We cannot achieve UHC without proper mental health in all the dimensions. And she said it very well. Better mental health will lead to better health outcomes, improved development in the country. But then, Chair, I also wanted to challenge all of us. As we are talking of increased health budgets at the county level, perhaps we need to present well-articulated, well-synthesized evidence to the decision makers at that level. Because the NHIF side is sorted. I can assure you that part of the reforms is reviewing the benefit package, expanding the scope of the benefit package, and there's work towards that. I think our contact person in the ministry in terms of mental health, Dr. Njogona, and team from Matari and the others are working on that to see that the benefit package is takes care of all Kenyans progressively. So at least that aspect is taken care of. But that alone will not help us. Okay, so we need also to look at how can we increase this other budget that flows to the health facility. So my challenge is how can we synthesize this data, Chair, present this data also to the MCAs who are also in charge of budgetary allocation at the county level to ensure that mental health services are well funded at the county level, while the national government is sorting in terms of insurance, because the moment you bring all Kenyans through mandatory health insurance means that every Kenyan is working with their money for access. It means you're working with your insurance card to be able to access health services. So once that is sorted, there's the other side of, is it called the supply or demand side? There's that side where you have to sort what is happening in the health facilities. That I may have insurance because it's mandatory, but when I go to the health facility, there's no HR, human resource, there's no equipment, there's no infrastructure, there's no, data systems. So that means we have to synthesize this data of 25–40% of outpatient, inpatient, show the implication, even disaggregate data per county, and continue engaging the Council of Governors, continue also engaging the MCAs as we sort the vision also at the higher level. So thank you, Chair. This is what I have. Thank you very much.
And thank you, Dr. Isabella, for that comprehensive presentation on UHC, mental health, parity and equity. We are so grateful, and I hope that there'll be some questions at the end. So still to remind the participants that we are happy to have you here. I see that on this webinar, we're actually having participants from all walks. I can see, I can see doctors, I can see psychologists, I can see Mike Onjenga, somewhere from USP, Dr. Kokonya from Masinde Muliro, Dr. Jacqueline Ochieng from Madara National Teaching and Referral Hospital, Mary Kitaka from True North, and many, many participants. Some of them are familiar to me. We are very happy to have all of you here. At the end of this webinar, we'll be having some Q&A. And given the time, I would urge that you lend us 15 minutes at the end so that we can have a Q&A in case there are questions. But at this time, I'm going to now move on to our next panelist from NHIF, and a lot has been said about NHIF. And now let's hear from the horse's mouth. We are privileged to have this afternoon Dr. Samson Kuhora, who is the head benefits, design and claims management at NHIF. He's a pharmacist by training, specializing in epidemiology and business management with more than 10 years of experience in government and donor-funded programs. And he seeks to pursue evidence-based, transformative and sustainable healthcare financing and monitoring systems and value-based financing models. So we are happy to have him this afternoon talk to us about NHIF options to offer comprehensive healthcare package. Karibu sana, Dr. Samson Kuhora. You will pardon us that for you may have to take the actual 15 minutes, although the earlier speakers may have taken a little longer. Welcome, Dr. Kuhora. I guess Dr. Kuhora may be muted. Dr. Kuhora, are you with us? Okay, I do not seem to see him, and I'm not sure whether. Oh, okay. Yes, Dr. Kuhora, can you? You are muted. Okay, let's see. Please, you can proceed now, sir.
Okay, thank you, Dr. Chitai. Good afternoon, everyone. I think from the introduction, this is the host speaking, and I'll give you a brief of the fund as a financier of healthcare services for more than 50 years. The scope of cover, the beneficiaries, the packages, and with a specific focus on mental health. So as an introduction, the fund was established in 1966 and placed under the Ministry of Health. It was transformed into a state corporation since 1998. The core mandate is to sustainably register members, collect revenues, and pay for healthcare benefits for members. In addition, in consultation with the Cabinet Secretary responsible for health, the fund sets criteria for declaration of hospitals who are to offer the services, regulations on contributions to be payable to the fund, and payments to be made out of the fund, and also contributes to national policy as far as healthcare financing and implementation of government policies is concerned. So overall, our core mandate is to secure financial protection against the catastrophic effects of out-of-pocket spending on healthcare for all Kenyans, and to ensure that there is prudent financial management for the members' contributions and other resources that are available to the fund. As a scope, we usually have 5-year strategic plans, and for the current plan that is running until 2022, the strategic goals that are geared towards UHC are one, to contribute to the universal healthcare coverage, with the main objective being coming up with a product mix that would be very relevant to the population that we are covering, to increase and sustain revenues that would be paying for the healthcare services, to enhance value-based financing and strategic procurement of healthcare benefits, to create a sustainable legal and regulatory framework for the financing of healthcare in the country, to strengthen governance and management systems as a way of improving internal efficiencies, to enhance strategic alliances like these ones by having collaborations, linkages, and joint forums, and of course to leverage on technology as a way of enhancing the service delivery for the members. In the roadmap towards UHC, the scope of cover for benefits has been increasing over time. In 1989, the only cover that was there was for inpatient services, but it has expanded over time to include outpatient, the surgical package, the oncology benefits, medical imaging, and evacuation services.
Can we get it? Oh, get a card.
Sorry?
Please go on and ask participants to mute themselves kindly. Go on, Dr.
The scope of cover, thank you. The scope of cover that is related to mental health is one that is very specific to mental health, is drug and substance abuse, rehabilitation and treatment. And for this particular benefit, it has been offered for more than 5 years. And then for the other conditions, they've been aggregated together with the inpatient, which is reimbursed through rebates, and for outpatient, which is reimbursed through capitation or the fee for service, depending on the scheme that the member is. As far as the beneficiaries are concerned, the beneficiaries are categorized into the national scheme or super cover, which includes the formal sector contributors. Those are the statutory contributors. They are the voluntary contributors, and we have the sponsored programs. And then we also have the employer financed programs, which are also called managed schemes. And this is mainly set out for the public sector and also for retirement benefits procured for retirees in the public sector. As far as providers are concerned, we engage all categories of providers, so as long as they have been registered and licensed by the respective boards. And the contracts that they're given are either comprehensively covered, where it means that it's a walk-in, walk-out for a patient with no out-of-pocket payment, or a non-comprehensive, where there's a provision for making an out-of-pocket payment to supplement the cost of the services that they see. I've mentioned earlier about the scope of benefits. We've been engaging with different stakeholders and doing a review of the benefits that have been offered by the fund. And this has generated quite a bit of insight regarding the different benefits. And I'll take you through what we have as far as the mental health services are concerned. As I mentioned earlier, drug and substance abuse treatment and rehabilitation is the one that is very specific to mental health. And from the utilization data, we finance about 950 cases per year at a cost of about 250 million. So far in the last financial year, that is between July last year and May this year, we had financed the management of 711 patients at a cost of 148.6 million. That translates to about 209,000 shillings, 100,000 shillings. It's 209,000 shillings per patient that has been sponsored. Then we've also looked at the historical data to come up with the most common conditions that we are financing. And how we do this internally is that we categorize all diagnoses using the ICD-10 codes. And these ICD-10 codes have chapters and blocks of diseases. So the diseases that are related to mental health, 4 categories of conditions account for more than 86% of the cases that have been financed by the fund. So mood or affective disorders account for about 27%. Mental and behavioral disorders due to psychoactive substance abuse account for 25%. schizophrenia, schizotypal, and delusional disorders account for 24%, and the neurotic, stress-related, and somatoform disorders account for about 10%. So that is the block of diseases that form the bulk of the conditions that we are financing presently. And using this data and in light of what we are projecting for the UHC, we've done some analytics based on the data that we have over time and also the utilization trend that is there. And from the projections, the fund is likely to spend up to 1.9 billion in conditions that are related to mental health. And this would translate to an annual expenditure of about 754 per household. So even as we are offering these benefits, we have to consider how best to make sure that it is sustainable. And to be able to do this, we are using the value-based financing models. And this includes the strategic procurement of the benefits and introducing the aspect of the outcomes, monitoring or rewarding the providers on the outcomes of the conditions being managed. That is through the payment for performance model. I will mention some of the challenges that have been discussed by different stakeholders as far as the benefit is concerned. There are those cross-cutting issues that affect the general performance of all the benefits of the fund. And the most common and what has been alluded to in the presentation by Dr. Isabella earlier is related to adverse selection. It seems that the fund attracts individuals who are being managed for chronic conditions. And from the data that we have, these account for almost 25% of the national scheme beneficiaries who enroll. And that is what we refer to as adverse selection, because this individual, it skews the utilization to a higher proportion compared to the population, because it's only attracting the individuals who actually need to spend. The other bit is the issue of distribution of the providers across the country. In a good number of the specialized benefits, the members are having to travel to urban areas. And for some of the conditions, 54% of the providers are in or around Nairobi. So it becomes a bit of a challenge when you look at it from the access point of view. Then there's the issue with the benefit package itself. There's been quite a bit of focus on the treatment aspect, and has been mentioned earlier, we need to go for early interventions. So the revisions to the benefits are seeking to have a collaborative effort when it comes to preventive and promotive health. This would include the kind of messaging that we do to the public and the kind of screening that is done. Then additionally, we're seeking to have early and optimized intervention before it gets to the point at which we're looking at admissions, because from the data that we have, the average cost of inpatient care for the same condition is about 4 to 5 times compared to outpatient services. So the early intervention will be a key factor in reducing the actual cost of healthcare for us. Then there have been issues raised about the reimbursement rates, and there are several proposals that have been made about moving from a fixed rate to looking at the actual cost of managing a condition. That is case-based financing, as opposed to having a block of conditions and reimbursing them at the same rate. There's the issue of the scope of cover, and whether the members who have been managed or the ones who have been financed are actually integrated well back into the community. And there's also the follow-up aspect. Then, as I mentioned, there is an issue with accessibility because of the distribution of the specialized healthcare providers in the country. And we're also seeing some trends as far as emerging patterns are concerned. The numbers for non-communicable diseases basically are on the rise. Therefore, we need to have a more active way of financing, or a more strategic way of financing healthcare as far as non-communicable diseases are concerned. So I'll mention what we are doing as far as the action plans are concerned. We are seeking the use of technology to improve on a number of operational efficiencies. We are looking at redesigning the mental and behavioral health package into one so that they are bundled together, and that will help in identifying the providers who are actually able or who have the right capacity to offer this benefit to the members. So what has been proposed is to move from a drug and substance abuse treatment and rehabilitation to a mental and behavioral health package that will encompass the 5 categories of the mental health conditions. This is an ongoing process, and we've had several engagements with the ministry with the support of WHO. And we're also looking at the costing of healthcare services, specifically how to, first of all, group the conditions using a DRG model, and then we cost each of those group of diseases where the cost of management is likely to be similar. And this would be able to shield even the healthcare providers and the beneficiaries from the out-of-pocket payments that they are being asked to pay to supplement for their care. We've also proposed national stakeholder forums, and for this case, it's been proposed that we would have a triennial national stakeholder forum that will bring the different categories of relevant stakeholders nationally and discuss issues specifically related to financing of healthcare services. And then, as I mentioned earlier, there's the issue of the integrated approach. There's what the fund can be able to do, there's what the county governments need to do, there's what the ministry needs to do to be able to integrate the care of not just this, but also all the other benefits that the fund is offering. And of course, as I mentioned earlier, value. What value are we getting from every shilling that is spent? And that is where payment for performance comes in. We've not been very good at monitoring aspects like clinical outcomes, and that is the direction that we are going. There are also health technology assessment indicators. That is the direction we are going. Thank you.
Thank you very much, Dr. Kuhora, for that great presentation, and indeed all the panelists for these very informative presentations this afternoon. And I know that there will be a number of questions to all of us, moving forward. And I encourage the participants to actually post those questions in the chat. At the end of the question session, we'll hear briefly from the Director of Mental Health at the Ministry of Health, Dr. Njuguna, who is here with us today. But I may just want to ask the first question to Dr. Kuhora. What informed the decision by NHIF to only partially cover substance use disorders? These are questions we get a lot of times from our patients. What was the thinking behind that? Was it, what was the rationale really for that? Because many think that it is discriminative. Yeah. Dr. Kuhora, are you able to come back?
Yes, thank you for that. And yeah, you're right. It's a question that has come up on so many occasions. What is used to prioritize what to cover? Because yes, there are challenges as far as resources are concerned. And the fact that we don't have an unlimited pool of resources, there has to be some level of prioritization. Exactly what informed having a specific DSC, it was from the records that have been presented, it was made, a decision was made on the basis of prevalence of some of the conditions and as a way of supporting the programs like MAT, which were coming up as far as the central government is concerned. But now going forward, we have developed a 12-point criteria of identifying and prioritizing which healthcare services to fund. And this one is cross-cutting. It looks at the internal factors in terms of sustainability, in terms of the costs, in terms of the population that needs that service, in terms of the proportion of the population that is likely to benefit most, in terms of a performance score that gives us what is the likely impact if you are to limit your scope to maybe the first 10 conditions as compared to financing the full scope, so that when we are covering a benefit, we're looking at the one which has a maximum impact as far as the Kenyan population is concerned. And it also has meso and macro factors, and this include the government policies that are there. We are looking at the social economic factors within the community. We are looking at prioritization as far as external factors like SDGs are concerned. So at the moment, we've developed a framework. It has 12 points, and it gives us a scored way of prioritizing what to finance and how much to finance in terms of the scope and in terms of what to reimburse. Do we do 100% reimbursement? Do we make a tiered reimbursement where it is maybe 50% and 50% out of pocket? That is a concept that is called CCP. Thank you.
All right, thank you very much, Dr. Kuhora. And Jacqueline Wambua had asked a question about which private insurance companies cover mental health in Kenya. So I don't know if anyone has a list of these private insurance companies, but we know what the law actually says about insurance coverage for mental conditions, that it is illegal to discriminate against coverage of mental illnesses, and therefore all insurance companies are obliged to cover mental illnesses just like physical illnesses. Speaking to even my colleagues, there's a big problem about both substance use conditions and conditions around suicidal behavior, like a suicide attempt, for example. Most insurance companies tend to be hesitant to cover, and they'll find all ways of evading the coverage. Yet suicidal behavior is as a result of, or is one of the symptoms really of mental ill health. So I mean, all private insurance companies are obliged to cover mental illness according to the Mental Health Act 1989. And there's a question also on what is being done about mental health awareness. I'm sure that Dr. Njuguna will be answering the question, as it comes on to give a brief remark. So, ladies and gentlemen, I think at this point in time, I know that we are a few minutes past time, but I will now welcome Dr. Njuguna to give us the closing remarks for this webinar. Karibu, Dr. Simon Njuguna, Director, Mental Health.
So thank you, Dr. Chitai. Thank you, all our participants. Thank you, our panelists. I think these have been very good discussions, and I think we'll continue with these discussions. My remarks is to thank all of you for participating in this deliberation. Our aim of having this deliberation is to move forward with all the stakeholders and come up with a number of things. Very important is to bring the issues of mental health parity and equity when it comes to insurance, and how we are looking at this. If you come across, if you look at our mental health action plan for 2021-2025, our aim is to ensure that that more persons who are seeking mental health services have a form of mental health care financing. And I agree with the speakers that the mental health care financing, not only looking at the insurance, is looking at how much budget allocation is coming from the county government, how much money is coming from philanthropy, how much money is coming from the private sector, the NGO, but as much as possible to reduce the out-of-pocket expenditure from the household. So that's one aspect, and that's a target we have put, that we want to see as many persons who are seeking services get a form of an insurance cover so that they don't spend from the pocket. The second element is, if they have this insurance, what are the benefits are they getting from them paying these 500 shillings every month? That they must be able to access some services as near as where they are as possible. When they go for these services, the services are of quality and they get the services they need. Because you may pay 500 shillings, but then when you go to a facility, the facility doesn't have medication, doesn't have human resource, then you don't get the value for your money for paying for that 500 shillings every month. So that's an issue about the services coverage and the benefits being covered by you paying this. Then the other question is the aspect of, we know the impact mental health has on our population, and what can we do for those people who can't be able to pay for the insurance? How will we consider, do we need to consider mental health care insurance package among the special package, where we have government taking care of a certain percentage of the population? So this is some kind of a conversation we have. If the government can't cover everyone, we know some country like Uganda has the insurance coverage for mental health services in quote free. That means the government is taking care of that cost. Or in Kenya, would we go for a process where we'll have people who have had very severe psychosocial disability due to the impact of the mental illness or any other aspect, unemployment, being out of their household, they're homeless, how can we have them, all of them covered? And then they're able to access the services. And then as it's mentioned earlier, the service coverage. It's a big problem we have in the country. So in our action plan in the next 5 years, we are trying to see that every county allocate money for purposes of getting services at every level of their counties by having programs, preventive and promotive programs, but then as also building the systems to have health services as close as possible to the community. These are the primary care level and at the community level. So these are big conversation we need. I invite all of you to participate. I think this is just beginning. We'll have other sessions, both boardroom sessions, stakeholder sessions. And at the end, our aim is to have a mental health and behavioral health package, which will cover both inpatient, outpatient, substance use treatment and rehabilitation, procedures being done, and also some community programs. So we don't want to be left behind. We want to be part and parcel of the universal health coverage agenda. And we are so happy that we have started this deliberation. And hopefully in the next, not a long time, maybe in a month's time, we should be able to share with you the first package. Probably we'll have agreed with NHIF, with the healthcare financing experts, the users, the caregivers, and everyone who is on board. So with those few remarks, again, I thank all of you for participating in this webinar and looking forward to concluding this agenda. Back to you, Dr. Chitai.
Yeah, thank you very much, Dr. Njuguna, for those great remarks. And at this point in time, I'll also just take this time to thank our panelists, thank our participants, and I know that there are many, many questions that may still need to be answered. So my encouragement is that we should continue this discussion, perhaps even online, and you can follow the official Twitter handle for the mental health department at MOH Mental Health. You can also follow Dr. Njuguna on Twitter. He's at Kahonge, if I'm not wrong. Then you can also follow at NHIF Kenya and at KPA Kenya, those handles, and you can tag them and continue this discussion. Otherwise, we thank you very much, and now you may leave at your own pleasure. Kwaherini.